Hello, my name is HeatherB. I'm a pediatric radiologist in the Department of Radiology at British Columbia Children's Hospital and at the University of British Columbia in Vancouver, Canada. I'm very happy to have been invited by the Singapore Congress of Radiology to record this presentation entitled Imaging Brachial Plexus Birth Injury and Glenohumeral Dysplasia for your viewing. I have no disclosures. At the end of this presentation, I hope that you will understand the etiology and sequela of brachial plexus birth injury, the imaging techniques used to understand glenoid development and humeral head subluxation before, during, and after treatment of brachial plexus birth injury, and the strengths and limitations of the imaging modalities available to us. Traction on and damage to the brachial plexus during delivery results in an injury known by several names in the literature, including brachial plexus birth palsy, birth-related brachial plexus injury, neonatal brachial plexus palsy, and obstetrical brachial plexus palsy. The term that is favored at my institution is brachial plexus birth injury, and that is the term that I will be using during the duration of this presentation. Brachial plexus birth injury occurs in somewhere between 0.4 and 4 cases per 1,000 births. The risk factors for brachial plexus birth injury are large for gestational age, shoulder dystocia, multiparity, prolonged labor, breech presentation at delivery, and an assisted or difficult delivery. The injuries that can occur at the time of a brachial plexus birth injury include a complete avulsion of the nerve root from the spinal cord, this being a preganglionic tear, or a postganglionic nerve root rupture or partial tear, which results during healing in a neuroma, or neuropraxia, which is damage to or stretching of a nerve root without axonal tear. These injuries most commonly involve the C5 and C6 nerve roots, with or without involvement of the C7 nerve root, and give rise to a clinical entity known as Erb's palsy. The majority of these injuries involve neuropraxia without nerve root avulsion or rupture, and 75% of children with brachial plexus birth injury will show complete recovery over the first 1 to 2 years of their life. Nerve root avulsion occurs very rarely, and in our institution we've only seen one case in the past 10 years. Nerve root avulsion is repaired by a microsurgical procedure, and prior to this the surgeon would like information on where the nerve root avulsions are occurring or at what levels. To do this, we undertake an MR study of the cervical spine and use heavily T2-weighted images to identify pseudomeningoceles, as indicated by the yellow arrows on these images, at the sites of preganglionic nerve root avulsion. Far more frequently, we are asked to image the sequela of brachial plexus birth injury. Nerve deficits occurring because of the damage to the nerve roots leads to an imbalance of muscle forces around the shoulder. This results in internal rotation of the shoulder, extension at the elbow, flexion at the wrist, and joint contractures, as in this child who has an Erb's palsy. The extent of injury and prognosis are variable and vary from a spontaneous recovery to permanent weakness and development of glenohumeral dysplasia. As demonstrated on these radiographs, glenohumeral dysplasia is characterized by posterior subluxation of the humeral head, an abnormal shape and axis of the glenoid fossa, a small flattened humeral head, acromial overgrowth or overriding, and not demonstrated on these plain films is muscle atrophy on the involved side. Treatment of brachial plexus birth injury includes microsurgical repair of nerve root avulsions and early treatment to prevent the sequela of brachial plexus birth injury. This treatment may involve physiotherapy, Botox to the uninvolved muscle groups, splinting, and at our institution, the Brachial Plexus Clinic has undertaken a program of splinting children in supination and external rotation, as shown on these images. Children may also undergo closed reduction or casting. Shoulder reconstruction and tendon transfers may be considered in older children with developed glenohumeral dysplasia. Shoulder ultrasound has been found to be useful in brachial plexus birth injury for evaluating the position of the humeral head relative to the glenoid. This was first described by Hunter and his colleagues in 1998. In this technique, the humeral head and glenoid are assessed from posteriorly through the infraspinatus muscle and across the humeral head. So the transducer is placed posteriorly as demonstrated by the blue bracket on these images. If you turn the image that I just had upside down, the view that you get during the ultrasound is presented on the right-hand side of the screen, where we are visualizing the bony scapular wing as a bright echogenic linear reflector on the ultrasound. The glenoid cartilage is represented as a hypoechoic structure. The humeral head is also a hypoechoic cartilaginous structure, and in this example there is ossification of the proximal humeral growth center. Measures of posterior humeral head subluxation have been developed and validated. One of the measures which assesses the degree of posterior subluxation is the alpha angle. The alpha angle is calculated from a line drawn over the right reflector of the scapula, as shown here, through the bony prominence of the bony margin of the glenoid. From that bony margin of the glenoid, a line is drawn tangentially adjacent to the humeral head, and the angle between these two lines is the alpha angle. The normal alpha angle should be less than 30 degrees. The second ultrasound measurement that has been validated is the posterior displacement of humeral head ratio. This is calculated by, again, drawing that line along the scapula through the bony glenoid and drawing a second line perpendicular to this, measuring the size of the humeral head, and then calculating a portion of the ratio of the humeral head that lies posterior to the scapular line versus the entire diameter of the humeral head. A normal measurement would be less than 50% of the humeral head lying posterior to the scapular line. There are many advantages to performing ultrasound over other imaging studies. It does not require sedation. There is no ionizing radiation. It is available and inexpensive. It's easy to perform in experienced hands. And very importantly, it allows a dynamic assessment. We can image with ultrasound while we are moving the shoulder from external to internal rotation or from internal to external rotation. And we can perform ultrasound with the child in a splint or within a cast. The limitations of ultrasound are limited visualization in children over 1 year of age due to the ossification center within the humeral head. We are often unable to visualize the anterior glenoid as we are imaging from posterior, and therefore we cannot measure glenoid version or classify glenoid configuration, which I will be discussing a little later in the talk. And of course, ultrasound, as other ultrasound examinations is ultrasound operator dependent. The technique that we use in imaging children with brachial plexus birth injury with shoulder ultrasound is to have the child lying on their side and with the shoulder being imaged up, or have the patient sitting facing their parent. We keep the arm that is being visualized in adduction with the elbow at 90 degrees of flexion. And we always examine both the affected and unaffected sides. We use a high-frequency linear array transducer, again posteriorly through the infraspinatus muscle to visualize the scapula, the glenoid, and the humeral head. These are examples of a child with an affected right shoulder. On the left, you can see the humeral head is well seated within the glenoid. The glenoid has a normal configuration, and the alpha angle here would be much less than 30 degrees. On the right-hand side, the humeral head is posteriorly dislocated, completely outside of the glenoid, and the glenoid is rounded and with a dysplastic configuration. We perform a dynamic assessment while moving the shoulder from internal rotation through external rotation, maintaining the elbow at 90 degrees of flexion to stabilize the scapula. And this is an example of the cine taken during motion of the shoulder from internal through external rotation. You can see the infraspinatus tendon moving the humeral head as the shoulder moves into external rotation. This is the very first patient that we attempted shoulder ultrasound in brachial plexus birth injury about 10 years ago. This child was about 10 months of age at the time and had had brachial plexus birth injury that was refractory to treatment to this point. We were able to see the humeral head, which is quite ossified because of the child's age, which was posteriorly subluxed relative to the rounded glenoid with an alpha angle greater than 30 degrees. When we moved the child from internal rotation into external rotation at the affected shoulder, the humeral head subluxation was reduced, with the humeral head now lying normally within the glenoid with an alpha angle less than 30 degrees. So we were very encouraged by this result on our very first patient on whom we attempted. This is another more recent case with the left humeral head posteriorly dislocated relative to the dysplastic glenoid in internal rotation. There is partial but not complete reduction of the humeral head into the dysplastic glenoid on external rotation. So these are the static images obtained. This is the cine that is obtained during the dynamic portion of the study, and you can see here the humeral head partially reducing but not completely reducing as we move from internal rotation through external rotation. This is the most recent example from our hospital. This child was being treated for brachial plexus birth injury. The ultrasound at approximately 3 months of age, the humeral head is partially subluxed posteriorly. This is on the top left-hand image. A month later, on May 27th, the degree of subluxation of the humeral head had progressed with a greater alpha angle, now close to 90 degrees. By June 17th, another month later, the humeral head was entirely dislocated posteriorly, so we're having progression of the deformity despite treatment in the supination and external rotation splint. The child then went to theater for a Botox injection into the opposing muscles and casting in external rotation. We were able to perform the ultrasound following Botox injection and placement of the cast, showing much improved position of the humeral head within the glenoid. Now, Botox doesn't work this quickly. It usually takes about 7 days to have maximum effect. So we are attributing the improvement in position and the good result from casting to muscle relaxation during anesthesia during the Botox injection and casting. The child has not yet come for follow-up. The imaging protocol for shoulder ultrasound at BC Children's Hospital includes imaging of both the symptomatic and asymptomatic shoulders. For the symptomatic shoulder or affected shoulder, we obtain static images in neutral position, that being the position that the patient holds their shoulder at rest, static images in maximum internal rotation, static images in maximum external rotation, a cine loop as we move the shoulder from internal through external rotation, a static image in splint if the child is being treated in splint, and we do one alpha angle measurement in each of these positions. For the unaffected or asymptomatic shoulder, we obtain a static image in internal rotation or neutral position, and we'll do alpha angle measurements if the alpha angle is not obviously normal. The report from an ultrasound performed for brachial plexus birth injury usually obtains some comment on the shoulder congruency or whether there is posterior subluxation of the humeral head. If the posterior subluxation does exist, does it reduce when the shoulder is moved into external rotation? A comment on shoulder congruency in splint. Measurements of the alpha angle in internal and external rotation. A comment on the size of the humeral head of the affected side versus the unaffected side, and a comment, if we are able to, on whether glenoid dysplasia is apparent or not. We are on occasion asked to image children with brachial plexus birth injury using shoulder MRI. The advantages of MRI over ultrasound are higher spatial resolution and contrast resolution. The ossification of the humeral head does not limit MRI evaluation in older children as it does on ultrasound. MRI allows assessment of the shape and axis of the glenoid, the position of the humeral head, the size and shape of the humeral head, and the volume of muscles around both the affected and unaffected shoulders. The limitations of MRI are that it requires sedation and it does not allow dynamic evaluation as ultrasound does. The technique we use for shoulder MRI is to have the patient supine with shoulders adducted unless they are being treated in an abduction cast. We image both shoulders in multiple planes and with multiple sequences, including T1 and T2 weighted sequences for better evaluation of muscle bulk and of the anatomy. But we must always include a cartilage-sensitive sequence for glenoid and humeral head evaluation. The example on this slide is a flash sequence. That's the cartilage-sensitive sequence that we use in evaluating children with brachial plexus birth injury. On MRI, we are able to evaluate the glenoid shape. The Birch classification has been developed to classify the shape of the glenoid. Type 1 is a normal concave glenoid. Type 2 is a dysplastic convex glenoid. And type 3 is a biconcave glenoid, which has two articular surfaces with the humeral head posteriorly subluxed and articulating with the most posterior articular surface. We are also able to measure the version of the glenoid or its tilt. The version angle is determined by measuring the angle between a line drawn down the axis of the scapula from the midpoint of the glenoid to the medial tip of the scapula, and a line drawn parallel to the the surface of the glenoid. This angle then has 90 degrees subtracted from it, resulting in a negative version angle, which would be retroversion, or a positive version angle, which would be antiversion. The glenoid version angle is variable and increases with age, so we must compare the version angle of the affected side and the unaffected side. And more than 5 degrees difference between the two shoulders is considered deformity. This is a cartilage-sensitive sequence in a child who had been successfully treated for brachial plexus birth injury. There is some difference in the axis in which the glenoid is held, but we can see both humeral heads are well seated within the glenoid, and we can measure the glenoid version bilaterally by drawing a line along the axis of the scapula from the midpoint of the glenoid to the most medial aspect of the scapula, and then drawing a line parallel to the glenoid. The angle subtended here, minus 90 degrees, would give us a small amount of retroversion bilaterally, which was symmetric. In this example, with a Birch type 3 dysplastic right glenoid and posterior subluxation of the right humeral head, when we draw the glenoid version, there is increased retroversion within the affected right shoulder. We can also measure the alpha angle, very similar to ultrasound, by drawing a line along the posterior surface of the scapula through the bony prominence of the scapula, and then drawing a line tangential to the humeral head. In this case, the alpha angle is increased due to the posterior subluxation and glenoid dysplasia. T1 weighted imaging is better for assessing the degree of muscle atrophy. In this case, the affected left shoulder demonstrates atrophy not only of the infraspinatus but also of the subscapularis musculature. We are uncommonly asked to do CT in children with brachial plexus birth injury. This is limited to older children who are being considered for reconstructive surgery of their shoulder. This isn't used in younger children because in younger children we then are not able to visualize the cartilaginous components of the glenoid and humeral head. The advantage of CT, of course, is that it allows 2D and 3D assessment of the osseous structures when reconstruction is being considered. Again, we can measure glenoid version and alpha angles very similar to on MRI. This is an example of a patient who underwent a CT scan for preoperative evaluation of glenoid dysplasia. The transverse images demonstrate the features of glenohumeral dysplasia within the right shoulder, with a small and flattened humeral head and abnormal access to the glenoid. The coronal multiplanar reconstruction then confirms the abnormal axis of the scapula and the glenoid, shows the overriding acromion and the small humeral head. Our surgeons also greatly appreciate a 3D volume rendered reconstruction of the shoulders using the same data set as demonstrated here. Again, demonstrating the degree of glenohumeral dysplasia and abnormality to both the glenoid and the humeral head. In summary, the imaging evaluation of the shoulder in children with brachial plexus birth injury can include ultrasound evaluation of the cartilaginous humeral head and its position relative to the glenoid, both in static position and dynamically as the shoulder is moved from internal rotation through external rotation. As children get older and assessment of the shape of the glenoid and the position of the humeral head is no longer possible by ultrasound, we can use MRI for assessment. CT has a role in evaluating the shoulder in older children who are being considered for reconstructive surgery of the scapula and glenoid or tendon and nerve transfers. This child, unfortunately, did not have a good outcome from splinting at a younger age, and at 6 years of age went on to have a wedge osteotomy of the scapula, which improved the function of the shoulder. And of course, we can now produce 3D printed models of the scapula for the surgeon prior to reconstruction from the CT data. These are references on imaging a brachial plexus birth injury that I have found useful. I would like to thank you for your attention to this presentation, to thank the organizers of the Singapore Congress of Radiology for inviting me to prepare and record this presentation, and also to my colleagues in the Brachial Plexus Clinic at BC Children's Hospital for their collaboration. Thank you.